Hello class and welcome to today's lecture on Chapter 25 of your Understanding Medical Surgical Nursing book published by F.A. Davis. This chapter will cover nursing care of patients with cardiac arrhythmias. As always, I recommend that as we go through the slides, take notes on your printed slides and keep your book handy. After the presentation, learners should be able to describe how electrical activity flows through the heart, list the 6 steps used for arrhythmia interpretation, and explain current medical treatments for cardiac arrhythmias. Additionally, learners should be able to discuss cardiac pacemakers and implantable cardioverter defibrillators and their uses, plan nursing care for patients with an arrhythmia, and plan nursing care for patients with an implanted device. We learned about the cardiac conduction system previously. Impulses are generated in the electrical conduction system of the heart to stimulate the mechanical cells of the heart to contract. Sinoatrial or SA node is the primary pacemaker of the heart and fires impulses at the rate of 60 to 100 beats per minute. There are other conduction sites in the heart as well, in case the SA node fails. These are located in the atrioventricular node and the ventricles. This protective mechanism is called the escape. AV node has the inherent rate of 40 to 60 beats per minute, which is adequate for survival. Ventricles have the inherent rate of 20 to 40 beats per minute, which is inadequate to meet the body's requirement for oxygen. Patients will start showing signs of inadequate cardiac output, including dyspnea, abnormal vital signs, and changes in level of consciousness. Immediate interventions are required for reperfusion. The impulse generated by the SA node travels via atrial conduction system to the AV node and causes the atria to contract. This is called atrial systole. The blood is pushed out of the atria into the relaxed ventricles. This is called ventricular diastole. The impulse is briefly delayed at the AV node to give time to atria to contract fully and the ventricles to fill with blood. The impulse picks up speed as it passes through the AV node and travels down the bundle of His, also known as the atrioventricular or AV bundle. The AV bundle branches into right and left bundle branches. The impulse continues to travel to Purkinje fibers, which causes the bilateral ventricles to contract almost simultaneously. Please refer to Figure 21.3 on page 342 in your books for conduction pathway. If you log into Davis Plus, you can visualize the electrical conduction system under the animation Cardiac Conduction. Cardiac cycle is the period from the beginning of one heartbeat to the beginning of the next. Cardiac cycle is the electrical representation of the impulse that stimulates depolarization, which is contraction, and repolarization or relaxation of the atria and the ventricles. An easier way to remember the difference between depolarization and repolarization is that both repolarization and relaxation start with the same RE. A typical cardiac cycle is made up of P wave, QRS complex, and a T wave. This diagram shows us the components of the cardiac cycle. You can see the P wave, the QRS complex, and the T wave. We will be discussing each component separately. Electrical activity of the heart can be recorded on an electrocardiogram or ECG or observed on the continuous cardiac monitor. ECG shows the heart's electrical activity at the moment it was collected. Electrodes placed on the patient's skin allow various views of the heart's electrical activity to be seen. Each view is called a lead. Thus 12 lead ECG equals 12 different cardiac views, 18 lead equals 18 views. Continuous monitoring can be done with 1, 2, or 12 leads. The intervals for the P wave, QRS complex, and the T wave are measured in seconds on the ECG graph paper. Graph paper is calibrated within a grid. Small squares are divided into heavy-lined blocks of 25 that are 5 squares wide and 5 squares high. Each small square is 0.04 seconds wide. 1/2 of a square is 0.02 seconds wide. Nothing smaller than 1/2 of a square is used. There are 5 small squares horizontally between 2 heavy vertical black lines. The waveforms are measured horizontally from left to right on the graph paper. The height of the waveforms, or the amplitude, is measured vertically. For the purpose of this class, we will be concerned with the squares on the horizontal axis of the grid. Here you can see a 6-second strip. The 6-second strip is divided into 2 3-second intervals. Each interval is made up of 15 big squares horizontally. Each big square has 5 small squares horizontally. These small squares measure time. Each small square equals 0.04 seconds. Thus, 5 small horizontal squares equal 0.20 seconds. That is, each big square is equal to 0.20 seconds. 5 of these big squares equal 1 second. Thus, we come back to 15 of the big squares equaling 3-second interval. In 1 minute, we have 1500 small squares. This is something we will be using later for interpretation of heart rhythm strips. Isoelectric line is the baseline represented by the straight line on a heart monitor. It occurs when there is no electrical current, such as the ECG is turned on but not attached to a person. It also occurs when the positive and negative electrical activity is equal. It is seen when there are no upward, that is positive, or downward, that is negative electrical wave deflections present. P wave is the first wave of the cardiac cycle and represents atrial depolarization, that is atrial contraction. When the SA node fires, the electrical impulse spreads from the right to the left atrium as well. Normal P wave is rounded and appears as a small hill. The PR interval, or PRI, represents the time it takes for the electrical impulse to travel from SA node to the AV node. PRI starts at the beginning of the P wave and ends at the beginning of the QRS complex. To measure PRI, count the small squares horizontally that the interval covers. Multiply the number of squares by 0.04 to identify the length of the PRI. Normal range for PRI is 0.12 to 0.20 seconds, that is 3 to 5 small horizontal squares. For example, in this figure, the PR interval is spread over 4 small squares, 1, 2, 3, and 4, from the beginning of the P wave to the beginning of the QRS complex. Each small square equals 0.04 seconds. Thus, PRI is 4 times 0.04 seconds equals 0.16 seconds, which falls under the normal range. The QRS complex represents the ventricular depolarization, that is, the ventricular contraction. It is made up of 3 waves, Q, R, and S. Q is the downward deflection after the P wave. The R wave is the first upward deflection after the P wave. The S wave is the first negative deflection after the R wave. S wave ends when it returns to the isoelectric line. All 3 waves are not always present in every QRS complex. However, it is still referred to as QRS complex and can be normal. QRS is larger than the P wave because the ventricles have more muscle mass. Thus, the QRS complex looks like a mountain on the ECG strip. The QRS complex represents the time it takes for the electrical impulse to travel from the AV node rapidly through the ventricles. To measure the QRS interval, count the number of squares from the wave that starts the QRS complex to the end of the wave that completes the QRS complex. For example, when all 3 waves Q, R, and S are present, measure from the beginning of the Q wave to the end of S wave. If only R and S are present, then measure from the beginning of the R to the end of S. If only R is present, measure from the beginning of R to the end of R. Normal QRS interval is 0.06 to 0.10 seconds, which is roughly 1.5 to 2.5 small squares. In your book on page 438, there is another wave with no R component. The wave will be called QS because it is not clear whether it is Q or S. Again, the QRS interval is measured from the beginning of QRS complex to the end of QRS complex. It should be less than or equal to 0.10 seconds. In this example, the QRS complex is spread over 2.5 small squares, which equals 0.10 seconds. We multiplied 2.5 times 0.04 seconds. T wave represents the ventricular repolarization. That is, the ventricles are relaxed at this time. Remember the RE at the start of both repolarization and relaxation? At this time, the ventricles are filling up with blood and getting ready to receive the next impulse. The T wave is a rounded wave. Compared to other waves on the ECG strip, this would be considered a medium-sized hill. In most leads, the T wave is a positive or upward deflection. It follows the QRS complex as the depolarization must occur before repolarization. The T wave ends when it returns to the isoelectric line. An inverted T wave can indicate cardiac ischemia. In this figure, you can see a T wave with a positive deflection, that is, it's upward, and a T wave with negative or inverted deflection, indicating ischemia. Another component of the cardiac cycle that we are going to learn about is the QT interval. The QT interval measures the time from the start of the Q wave to the end of T wave. This interval represents the time of ventricular depolarization and repolarization. Normal ranges are 0.34 to 0.43 seconds. These vary based on gender, heart rate, and age. QT chart for identifying normal values is used. Prolonged or shortened QT intervals can lead to ventricular arrhythmias. Abnormal rhythms can result from genetic causes, heart conditions, electrolyte imbalances, or medications that can prolong the QT interval. U wave is small and not seen often. It occurs shortly after T wave. It represents hypokalemia. Here you can see the U wave following the T wave. ST segment represents the time from the completion of a contraction or depolarization to recovery or repolarization or relaxation of myocardial muscles for the next impulse. ST segment starts at the end of QRS complex and ends at the beginning of T wave. ST segment is checked when patients experience chest pain. Transmural means across all layers. On an ECG, non-transmural ischemia may show as inverted or depressed ST segment. Transmural ischemia may be represented as an elevation from the isoelectric line. Here you can see the ST segment beginning from the end of QRS complex and ending at the beginning of T wave. Here you can see ST segment depression in the non-transmural ischemia. When ischemia affects all the layers of the myocardium or transmural, ST elevation may be noted. So now that we are familiar with the basics of cardiac cycle, we are going to learn how to interpret the cardiac rhythm. It is imperative that we use a systematic method for interpreting the ECG rhythms to ensure understanding of the items being examined and that nothing is missed or overlooked. There are 6 steps as you can see on the slide. The first 5 steps identify the ECG rhythm according to the 5 rules for each arrhythmia. The sixth step involves QT interval measurement. For the purpose of this class, we are going to concentrate on the first five. A 6-second ECG strip is used when interpreting rhythms. In the first step, we assess the regularity of the rhythm by looking at the R to R spacing on the ECG strip. A normal rhythm will show same spacing between each R to R with a rare variation of no greater than 2 small squares. We can either count the small squares between each R wave or use caliper to measure the R to R spacing. To use the caliper for measuring R waves, place one metal point on an R wave. Place the second point in the same location on the next R wave. At this point, stabilize the caliper as you have obtained the baseline distance. Without changing the distance between the two caliper points, move the caliper from R wave to R wave across the ECG strip to see if the R waves are evenly spaced. In case we do not have caliper available, we can use paper by placing a mark at the peak of one R wave and then at the peak of the other R wave. If the distance remains the same, the rhythm is regular. If the distance is not the same or varies usually greater than 2 small squares, then this will be considered an irregular rhythm. If the irregularity presents in a predictable pattern, then the rhythm is regularly irregular. If the irregularity occurs without a specific pattern, then this is called an irregularly irregular rhythm. The second step is to calculate a 1-minute heart rate. There are two methods, one for determining heart rate in a regular rhythm and the other for irregular rhythm. Note that at the top of ECG paper are the bolded vertical marks at 3-second intervals. The smaller marks are at 1-second intervals. As we learned previously, each of the small square is equal to 0.04 seconds. 5 small squares are equal to 0.20 seconds. 5 of these boxes are equal to 1 second, hence the 1-second interval. For regular rhythm, count the number of small squares between two R waves. Divide the number into 1500. This gives the beats per minute because 1500 small squares equal 1 minute. This is an accurate method for determining heart rate. A rate meter is visual paper copy of this mathematical calculation for an entire 6-second ECG strip. The nurse views it to calculate the 1-minute heart rate. For irregular rhythms, a 6-second method is used. This method is also used when we need a rapid estimate of regular heart rhythm. This, however, is not the most accurate method for regular rhythms. So for this method, you want to count the number of R waves in a 6-second strip, that is the 3 vertical marks. Multiply this number by 10. We are multiplying by 10 because the 6 seconds appear 10 times in a minute. That is 6 times 10 equals 60 seconds or 1 minute. For the regular rhythm 6-second strip in the slide, we can determine heart rate by using both methods. Using the first method, we can count 22 small squares. If we divide 1500 by 22, we will get 68 beats per minute. Using the 6-second method, we can count 7 R waves in the 6-second strip. Multiplied by 10 equals 70 beats per minute, which is close to 68 beats per minute. If you use your caliper or marks on a piece of paper to measure the distance between the R waves, you will see that the rhythm is irregular. Using the 6-second method, we calculate the heart rate to be 7 times 10 equals 70 beats per minute. After determining the regularity or irregularity of the heart rhythm and the heart rate, the third step is to see whether A. There is one P wave in front of every QRS complex. B. If the P waves are regularly occurring. And C. If the P waves all look alike. If the P waves meet the criteria, this is considered normal. If not, we need to further investigate the arrhythmia. The fourth step is to measure the PR intervals and determine if they are normal, that is within the range of 0.12 to 0.20 seconds and constant. If the intervals vary, then we need to note whether there is a pattern to the variation. Remember, the PR interval is from the beginning of the P wave to the beginning of the QRS complex. The fifth step is to determine whether the QRS interval is within the normal range of 0.6 to 0.10 seconds. Abnormalities require further examination. The sixth and final step in patients with chest pain would be to determine the QT interval to ensure that it is not shortened or prolonged, as that can lead to arrhythmias. Abnormal QTs should be reported to the HCP. Normal sinus rhythm is the heart's normal rhythm which originates in the SA node. Remember that the SA node fires at a rate of 60 to 100 beats per minute. Normal sinus rhythm has complete, regular cardiac cycles at 60 to 100 beats per minute. The rules for normal sinus rhythm are: the rhythm is regular, the heart rate is 60 to 100 beats per minute, P waves are rounded upright before each QRS interval, PR interval is 0.12 to 0.20 seconds, and QRS interval is 0.06 to 0.10 seconds. An arrhythmia is also known as dysrhythmia. It is an abnormal rhythm of the heart. Arrhythmias can arise because of several mechanisms. Examples of these mechanisms are disturbances in the formation of an impulse or in the conduction of the impulse. When impulse formation is disturbed, an impulse may arise from the atria, the AV node, or the ventricles instead of the SA node. This can give rise to increased or decreased heart rate, early or late beats, or atrial or ventricular fibrillation. The disturbances in conduction causes the impulse to be blocked within the electrical conduction system, as in heart block or right or left bundle branch block. Rhythms originating in the SA nodes are called sinus rhythms. Disturbances in conduction from SA node can cause irregular rhythms or abnormal heart rates. Arrhythmias from SA node are rarely dangerous. Sinus bradycardia is a slow arrhythmia that originates in the sinoatrial node. Sinus tachycardia is a fast arrhythmia that originates in the sinoatrial node. Bradycardia is a heart rate slower than 60 beats per minute. It has the same cardiac cycle components as the normal sinus rhythm, except that the rate is slower. The slower rate is caused by less impulses originating from the SA node. Medications such as digoxin, which is also known as lanoxin, myocardial infarction, MI, and electrolyte imbalances can cause bradycardia. Just a pop quiz, which electrolyte imbalance do you think can cause bradycardia? Well-conditioned athletes can also have slower heart rates because their hearts function very efficiently. In the ECG strips on the slide, the distance from R to R is equal. There are 39 small squares between two R waves. If we divide 1500, which is the number of small squares in 1 minute, by 39, the heart rate is 38 beats per minute. Heart rate of 38 beats per minute is less than the range of 60 to 100 beats per minute. Hence, this rhythm will be categorized as sinus bradycardia. So, for the sinus bradycardia, the rhythm will be regular, heart rate is less than 60 beats per minute, P waves are still rounded upright before each QRS complex and alike. PR interval is 0.12 to 0.20 seconds, and the QRS interval is less than or equal to 0.10 seconds. Bradycardia can be asymptomatic or symptomatic. Symptomatic bradycardia can cause decreased blood pressure, respiratory distress, diminished or absent peripheral pulses, fatigue, or syncope. No treatment is needed for asymptomatic patients. The underlying cause must be addressed for correction. For symptomatic patient, begin treatment while cause is corrected. Treatment may include IV atropine or infusions of dopamine or epinephrine. Transcutaneous pacing is considered if atropine is ineffective. Transvenous pacing can also be considered. Tachycardia is defined as a heart rate greater than 100 beats per minute. It originates from the SA node, thus the use of the word sinus. The cardiac cycle components are the same as in normal sinus rhythm, except that the heart rate is faster. It can be caused by physical activity, hemorrhage, shock, medications such as epinephrine, atropine, or nitrates, dehydration, fever, myocardial infarction, electrolyte imbalance, fear, and anxiety. Tachycardia occurs as a compensatory mechanism for hypoxia. It helps produce additional cardiac output to deliver oxygen to the tissues. In the ECG strip on the slide, the distance from R to R is equal. There are 12 small squares between the two R waves. If we divide 1500, which is the number of small squares in 1 minute, by 12, the heart rate is 125 beats per minute. Heart rate of 125 beats per minute is greater than the range of 60 to 100 beats per minute. Hence, this rhythm will be categorized as sinus tachycardia. So, for the sinus tachycardia, rhythm is regular, heart rate is 101 to 180 beats per minute, P waves are rounded upright before each QRS complex and alike, PR interval is equal to 0.12 to 0.20 seconds, and the QRS interval is less than or equal to 0.10 seconds. Sinus tachycardia can be asymptomatic. A very rapid rate, usually greater than 150 beats per minute, that is sustained over a long period of time, may cause symptoms. The symptoms may include angina, dyspnea, syncope, or tachypnea. Older patients can become symptomatic more rapidly than younger patients. Patients with MI may not tolerate a rapid heart rate and may experience more severe symptoms because of increased cardiac workload. If the patient is stable, obtain an ECG and treat the cause. Medications such as adenosine or adenocard, beta blockers, or calcium channel blockers are considered to slow the heart rate equal to or greater than 150 beats per minute. Please see the table 25.2 on pages 443 and 444 for further information on the medications used for treatment of arrhythmias. Treatment is intended to decrease the heart's workload and correct the cause. For example, in hemorrhage, stopping the bleeding and treating the cause typically returns the heart rate to normal. In this section, we are going to learn about atrial arrhythmias. Impulses can be initiated in all areas of the heart. SA node is the primary pacemaker, but if the atria begin to generate impulses faster than the SA node, they become the primary pacemaker. Atrial rhythms are usually faster than 100 beats per minute and can exceed 200 beats per minute. When an impulse originates outside of the SA node, the P waves produced look different than the normal rounded P waves from the SA node. They may appear flatter, notched, or peaked. This indicates that the SA node is not controlling the heart rate. The atrial impulses travel to the ventricles and initiate a normal-shaped QRS complex after each P wave. Supraventricular arrhythmia are arrhythmias originating above the ventricles. The classic sign will be that the QRS complex is less than or equal to 0.10 seconds in the presence of an arrhythmia. We will further discuss premature atrial contractions, atrial flutter, and atrial fibrillation in the next slides. The word premature should give you the clue that this arrhythmia refers to early. Premature atrial contractions are caused when the atria fire an impulse before the SA node fires. This results in early or premature beat. If the underlying rhythm is normal sinus rhythm, the distance between the R waves is the same, except when the early beat occurs. When looking at the ECG strip, A shortened R to R interval is seen when the premature beat occurs. The R wave before the PAC and the R wave of the PAC are closer together, followed by a pause and then the regular beat. Causes of PAC include hypoxia, cigarette smoking, stress, myocardial ischemia, enlarged atria in the valvular disorders, medications such as digoxin, electrolyte imbalances, atrial fibrillation onset, and heart failure. So the premature atrial contractions or PACs interrupt rhythm. The heart rate is per the underlying rhythm. For example, if it's normal sinus rhythm, the heart rate can be from 60 to 100 beats per minute. The P waves have an early beat. They can be abnormally shaped. The PR interval is usually normal, but the premature beat could have shortened or prolonged PRI. The QRS interval is less than or equal to 10 seconds, indicates normal conduction to ventricles. PACs can occur in healthy individuals as well as those with diseased heart. No symptoms may be noted. If several PACs occur one after the other, the patient may experience palpitations. Typically, PACs are not serious and often require no treatment other than correction of the cause. Frequent PACs indicate atrial irritability. This can worsen into other atrial arrhythmias. Beta blockers can be administered to slow the heart rate. Next, we are going to talk about atrial flutter. In atrial flutter, the atria contract or flutter at a rate of 250 to 350 beats per minute. The very rapid P waves appear as flutter or F waves on the ECG. You will see a sawtooth pattern, just like right here. Some impulses get through the AV node and reach the ventricles. Normal QRS complex is initiated. There may be 2 to 4 F waves between QRS complexes. If impulses pass through the AV node at a consistent rate, the rhythm is regular. The classic characteristic of atrial flutter are more than one P wave before the QRS complex, a sawtooth pattern of P waves, and an atrial rate of 250 to 350 beats per minute. So for this example, you can see that for every one QRS complex, there are 4 P waves. So the ratio is 4:1. Causes of atrial flutter may include rheumatic or ischemic heart diseases, CHF, hypertension, pericarditis, pulmonary embolism, and postoperative coronary artery bypass surgery. Many medications can also cause this arrhythmia. So for atrial flutter, the atrial rhythm could be regular, ventricular rhythm could be regular or irregular depending on consistency of AV conduction of impulses. Ventricular heart rate could vary. The P waves could be fluttering or forming F waves, sawtooth pattern. The PR interval is non-measurable, and the QRS interval is less than or equal to 0.10 seconds. The presence of symptoms in atrial flutter depends on the ventricular rate. If the ventricular rate is normal, usually no symptoms are present. If the rate is rapid, the patient may experience palpitations, angina, or dyspnea. For atrial flutter, treatment is guided by the ventricular rate and adequacy of cardiac output. Goal is to control the ventricular rate with conversion to normal sinus rhythm. For an unstable patient with rapid ventricular rate, synchronized cardioversion or electrical shock is used. Medications such as calcium channel blockers can be used to control the ventricular rate. Please refer to Table 25.2 for more details. Antiarrhythmic medications are used to convert atrial flutter. To terminate the atrial flutter in symptomatic patients, catheter ablation, usually in the right atrium, may be done. Now we are going to talk about a very common arrhythmia, which is the atrial fibrillation. Atrial fibrillation is an extremely rapid and chaotic atrial rate. An atrial rate of 350 to 600 beats per minute can occur. However, the AV node blocks most of the impulses, thus the ventricular rate is much lower than the atrial rate. No definable P waves can be found or measured because at this time the atria are fibrillating or quivering rather than beating effectively. A wavy pattern is produced on the ECG. Because the atrial rate is so irregular and only a few of the impulses are allowed to pass through the AV node, the R waves are irregular. The ventricular rates vary from normal to rapid. Atrial fibrillation can be self-limiting, persistent, or permanent, which doubles the risk of death. Stroke risk is increased with atrial fibrillation. This is due to the risk of thrombus formation in the atria because of blood stasis caused by poor emptying of blood from the quivering atria. Atrial fibrillation increases with age, 65 and above, especially in those with heart disease. Causes can include cardiac surgery, heart failure, hypertension, heart valve disease, myocardial infarction, hyperthyroidism, emphysema, sleep apnea, and some medications. The cause may be unknown at times. In AFib, the rhythm is irregularly irregular. Atrial heart rate is not measurable. Ventricular heart rate, if less than 100, is a controlled response. If greater than 100, it's a rapid ventricular response. P waves, there are no identifiable P waves. There's non-measurable PR interval. The QRS interval is less than or equal to 0.10 seconds. Patients with AFib may feel the irregular rhythm, may describe palpitations, a racing heart, or a skipping heartbeat. They may feel shortness of breath, dizziness, or chest discomfort. The radial pulses may be faint because of a decreased stroke volume, which is the volume of blood ejected with each contraction. If the ventricular rhythm is rapid and sustained, the patient can go into left-sided heart failure. The goal of the treatment is to control rate, prevent thromboembolism, and restore normal rhythm. For an unstable patient, synchronized cardioversion is done immediately to try to return the heart to normal sinus rhythm. For stable patients, medications to control the ventricular rate are used, including beta blockers, calcium channel blockers, or digoxin. Anticoagulant therapy is given to reduce thrombi and stroke risk. Pharmacological or electric cardioversion may be used to convert the rhythm to normal sinus rhythm. It should be done after sufficient anticoagulation, 3 to 4 weeks, to stabilize or resolve any existing blood clots in the atria. This prevents them from being dislodged and causing a stroke. Rhythm control medications such as sodium or potassium channel blockers are used to restore and maintain normal sinus rhythm. If the underlying cause is known, it is treated. If the patients do not respond to medications or electrical cardioversion, other therapies may be used. Catheter ablation may be used to cure AFib. It aims to isolate impulses coming from the pulmonary veins, or the AV node. Most of the AFib impulses arise from the pulmonary veins. Intracardiac echocardiography maps the area of the heart requiring treatment. Then released energy such as cryothermy or radiofrequency energy creates lesions within all 4 pulmonary veins or near the AV node. The lesions heal and scar. This blocks those pathways to future impulses. Post-procedural care is similar to post-angioplasty or post-cardiac catheter care as discussed in the earlier chapter 21. Surgical maze procedure is often done as minimally invasive robotic-guided surgery. Incisions are made in the atria that create a maze or route for electrical impulses to travel to the AV node. These impulses stay on the route because scar tissue surrounds the incision sites. As the name implies, in the third-degree AV block, the SA node impulses are blocked and do not reach the ventricles to stimulate contraction. This is also known as complete heart block or the third-degree heart block. Remember the compensatory mechanisms that kick in when the SA node impulses are not functioning? So in this case, the escape pacemakers called the junctional, that is the AV node, or the ventricular, must produce electrical impulses to cause ventricular contraction, or else cardiac arrest will occur. Depending on the origin of the escape beat, the QRS complex, that's right here, Q, R, and S complex, may be narrow or wide on the ECG. Typically, junctional impulse will cause narrow QRS complex and the ventricular impulse will cause a wide QRS complex. Normal P waves march across the ECG strip at a constant P-to-P interval without any relationship to the regularly occurring but slower QRS complexes. So here you can see the P waves are occurring at a regular interval irrespective of the QRS complexes. So they are both doing their own thing. For rhythm in the third degree AV block, the P-to-P interval is regular, R-to-R interval is regular, atria and ventricles are being controlled by separate electrical impulses from foci that are firing regularly. We previously talked about the different heart rates generated by different impulses. The impulses from junctional focus such as AV node generates a heart rate of 40 to 60 beats per minute, which will work for some time. However, as the heart rate decreases, the ability of the heart to perfuse the body with oxygen-saturated blood decreases. So again, the rhythm is regular. Atria and ventricles are independent of each other. The atrial heart rate is 60 to 800 beats per minute, 20 to 40 beats per minute if it's the ventricle focus, 40 to 60 beats per minute if it's junctional focus. P waves are normal, rounded, upright, alike, and there are more P waves than QRS complexes. They may occur within the QRS complex or upon a T wave. The PR interval is none as no P wave conduction to ventricles is occurring. The QRS interval, if it's greater than 0.10 seconds, then it's a ventricular focus, or if it's less than or equal to 0.10 second, then it's junctional focus. To summarize, in the third degree heart block, electrical impulses are not conducted from SA node to stimulate ventricles to contract. The normal P waves are seen on ECG. The escape impulses, junctional or ventricular, are required for survival. There is no relationship between the atria and the ventricles. There are more P waves than QRS complexes, and there is no relationship between P waves and QRS complexes. Cardiac ischemia or infarction, hyperkalemia, infection, antiarrhythmic medications, or digoxin toxicity are some common causes of complete heart block. With narrow QRS complex rhythms, junctional or AV node, fewer symptoms such as dizziness, chest pain, and fatigue is experienced. Remember that at this time, the heart is beating at 40 to 60 beats per minute. Typically, severe symptoms such as confusion, dyspnea, severe chest pain, hypotension, or syncope are associated with wide QRS complex rhythms or the ventricular foci. At this time, the heart is beating at 20 to 40 beats per minute. Needless to say, third-degree heart block or complete heart block is a medical emergency. Oxygen is administered. For symptomatic patients, transcutaneous pacing is needed immediately. Atropine may be carefully considered if the patient is not symptomatic. Permanent pacemaker may be required for the rest of the patient's life. Temporary pacemaker may be used until the permanent pacemaker can be implanted. If medication toxicity is the cause, the complete heart block may be gone if the toxicity is resolved. A temporary pacemaker may be needed until this occurs. We will be discussing ventricular arrhythmias in this section. Ventricular arrhythmias can be potentially deadly. We will go over premature ventricular contractions or PVCs, ventricular tachycardia, and ventricular fibrillation. Premature ventricular contractions, or PVCs, originate in the ventricles from an ectopic focus. The word ectopic refers to an abnormal place, such as ectopic pregnancies in the fallopian tubes. In this case, the irritable ventricles fire prematurely before the SA node does, which is the primary pacemaker. When the ventricles fire first, the impulses are not conducted normally through the electrical pathway. Remember the electrical pathway? We have the SA node, the AV node, bundle of His or atrioventricular bundle, left and right bundle branches, and the Purkinje fibers. This results in a wide or greater than 0.10 seconds bizarre QRS complex on the ECG. Use of caffeine or alcohol, anxiety, hypokalemia, cardiomyopathy, ischemia, and MI are common causes of PVCs. In premature ventricular contractions, the rhythm depends on the underlying rhythm. The PVC interrupts that rhythm. The heart rate depends on the underlying rhythm. P waves are absent before PVC QRS complexes. PR interval is none for PVCs, and QRS interval for the PVCs is greater than 0.10 seconds. T wave is in the opposite direction of QRS complex, that is, QRS is upright, T downward, or QRS downward, and the T is upright. PVCs can occur in different shapes. Unifocal PVCs all look the same because they come from the same irritable ventricular area. Multifocal PVCs do not look the same because they are originating from several irritable areas in the ventricle. There can be several repetitive cycles or patterns of PVCs. Bigeminy occurs every other beat, a normal beat, and then a PVC. Trigeminy occurs every third beat, two normal beats, and then a PVC. Quadrigeminy occurs every fourth beat, three normal beats, and then a PVC. When two PVCs occur together, they're called a couplet or a pair. If three or more PVCs occur together, they're called run of PVCs or ventricular tachycardia. You can see here that the PVC is occurring every other beat. A normal beat and then a PVC. A normal beat and then a PVC. So when it occurs every other beat, it's a bigeminal PVC. Patients may describe a skipped beat or palpitations with PVCs. If the PVCs are frequent, cardiac output can be decreased, which may lead to fatigue, dizziness, or more severe arrhythmias. Treatment depends on the type and number of PVCs and if the patient is symptomatic. Occasional PVCs do not usually require treatment. However, if the PVCs are more than 6 per minute, regularly occurring, multifocal, falling on T wave, or caused by MI, they can be dangerous. So when the PVC falls on T wave, it's called R on T phenomena, which can trigger life-threatening arrhythmias. Antidysrhythmic agents such as lidocaine or xylocaine and beta blockers that depress myocardial activity are used to treat PVCs. The occurrence of three or more PVCs in a row is called ventricular tachycardia, VT. It results from the continuous firing of an ectopic ventricular focus. During VT, the ventricles become the pacemaker of the heart rather than the SA node. The pathway of the ventricular impulses is different from the normal conduction, producing a wide or greater than 0.10 seconds bizarre QRS complex. Myocardial irritability, MI, and cardiomyopathy are common causes of VT. Respiratory acidosis, hypokalemia, digoxin toxicity, cardiac catheters, and pacing wires can also produce VT. In ventricular tachycardia, the rhythm is usually regular, may have some irregularity. The heart rate is 150 to 250 ventricular beats per minute. The slow ventricular tachycardia is less than 150 beats per minute. P waves are absent. PR interval is none because there are no P waves. QRS interval is greater than 0.10 seconds. Patients experience a sudden onset of rapid heart rate. They can experience dyspnea, palpitations, and lightheadedness. Angina can occur. Seriousness of VT is determined by the duration of arrhythmia. Sustained VT compromises the cardiac output. It can become pulseless VT. In stable patients, antidysrhythmic medications are used. If the patient is pulseless or not breathing, cardiopulmonary resuscitation or CPR and immediate defibrillation are required. Advanced cardiac life support or ACLS protocols for pulseless VT treatment are used. Medications may include epinephrine and lidocaine or amiodarone. Next, we are going to talk about ventricular fibrillation or VF or VFib. This occurs when many ectopic ventricular foci fire at the same time. Ventricular activity is chaotic with no discernible waves. The ventricle quivers and is unable to initiate a contraction. There is complete loss of cardiac output. If this rhythm is not corrected immediately, then death will occur. Hyperkalemia, hypomagnesemia, electrocution, coronary artery disease, and MI are all possible causes of VF. Placement of intracardiac catheters and cardiac pacing wires can also lead to ventricular irritability and then VF. Ventricular fibrillation rules include chaotic and extremely irregular rhythm. The heart rate is not measurable, P waves are none, PR interval is none, and QRS interval is none. Patients experiencing VFib will lose consciousness immediately. There are no heart sounds, peripheral pulses, or blood pressure readings. This indicates circulatory collapse. Respiratory arrest, cyanosis, and pupil dilation occur. Immediate defibrillation is the best treatment for terminating ventricular fibrillation. Time is crucial for survival. CPR is initiated until defibrillator is available. Automatic external defibrillator, also known as the AED, provides quick access to user-friendly technology for defibrillation. Endotracheal tube or ETT with oxygen supports the respiratory function. Administer meds according to the ACLS protocol, including epinephrine and amiodarone or lidocaine. Asystole, or the silent heart, is the absence of any electrical activity within cardiac muscle. This is what we call a cardiac arrest. A straight line appears on the ECG strip. Asystole rules include: there is no rhythm, there is no heart rate, there are no P waves, there are no PR intervals, and there are no QRS intervals. Patients in asystole are unconscious and unresponsive. There are no heart sounds, peripheral pulses, blood pressure readings, or respirations. They go in respiratory arrest. There is cyanosis and pupil dilation. For therapeutic interventions in asystole, the CPR needs to be initiated immediately. ETT, or endotracheal tube, and oxygen supports the respirations. Epinephrine is administered per ACLS protocols and treat the reversible causes. Pacemakers are used to generate an electrical impulse when there is a problem with the heart's conduction system. Permanent pacemakers are used for symptomatic bradycardia and third-degree AV block. Pacemakers can be temporary, that is epicardial, transcutaneous, or transverse, or they can be permanent. The newest advance in pacemaker technology is the leadless pacemaker. Temporary pacemakers can treat bradycardia or tachycardia when the conditions do not respond to medication or synchronized cardioversion. They may also be used after an MI to allow time for the heart to heal. The temporary pacemaker becomes the electrical conducting system. It stimulates the atria and the ventricles to contract and maintain cardiac output. Temporary pacemakers can be inserted during valve or open heart surgery. These are epicardial. They can also be used in cardiac cath lab or critical care unit for emergency treatment. These are transvenous. They are kept in place until surgery is scheduled to implant a permanent pacemaker. Transcutaneous pacemakers are easy and quick to apply. Impulses are delivered from the external generator via electrodes on the skin to the heart. The electrodes are placed on the chest and back. Permanent pacemaker implantation uses fluoroscopy, a screen that shows an image similar to radiograph. The pacemaker generator is implanted subcutaneously. It is attached to leads, which are insulating conducting wires that are inserted via a vein into the heart. The lead then delivers an impulse directly into the heart wall. Single lead pacemaker delivers impulses to either the right atrium or the right ventricle into which it was placed. Dual chamber pacemakers have two leads, one for right atrium, one for right ventricle. Both chambers can be paced. Activity responsive pacemakers provide a rate range and allow changes in response to a patient's activity level. This provides the patient with greater flexibility for increasing cardiac output as needed. Leadless pacemaker is implanted into the right ventricle with no leads. Everything is contained within the pacemaker. It is inserted via the leg veins, no chest incision is needed. Leadless pacemaker is the size of a vitamin capsule. The battery can last about 12 years. At the time of this F.A. Davis text, a leadless pacemaker is only available for single-chamber right ventricular pacing. Here you can see the dual-chamber pacemaker with one lead in the right atrium and one lead in the right ventricle. When the patient is in a paced rhythm, a small vertical spike is seen on the ECG strip at the start of the paced beat. The spike signifies electrical stimulus. If atria are being paced, then the spike will appear before the P wave. If the ventricles are being paced, the spike will appear before the QRS complex. Patients may have 100% paced beats, a mixture of their beats and paced beats, or 100% their own beats. Pacemakers should not be fired during patients' own beats. Some problems that can occur with pacemaker include failure to sense a patient's own beat, failure to pace because of a malfunction of the pulse generator, and failure to capture, which is the heart's lack of depolarization. So for patients with pacemakers, monitor the patient's heart rhythm, apical pulse, and incision after implantation of pacemaker. Irregular heart rhythm or a rate slower than the pacemaker set rate can indicate pacemaker malfunction. Any changes in heart rhythm, changes in vitals are to be reported immediately to the healthcare provider. Patient may have surgery as an outpatient or stay overnight in the hospital. Patients who have pacemakers should receive education related to incision care, activity restrictions, symptoms or infections signed to report, pacemaker ID card, and periodic pacemaker checks. Additional education for patients with pacemaker may include educating patients that microwaves are safe and can be used. Security devices are safe but can be a trigger, so they should really avoid hand wand. Revo MRI Sure Scan pacing system is safe. Electromagnetic devices to avoid could be MRI, welder, radio tower, touching running auto engine, and move away from electromagnetic devices if they become asymptomatic. We learned about pulseless ventricular tachycardia and ventricular fibrillation. These are lethal ventricular arrhythmias. Defibrillation is a life-saving procedure that delivers an electric shock to attempt to reset the heart's rhythm. Saline pads or pads with conductive jelly are placed on the patient's chest. They prevent electrical burns and promote electrical conduction of electrical charge. The defibrillator is charged and then the pedals are pressed firmly and evenly against the chest wall to prevent burns or electrical arcing. It is imperative that the person who is defibrillating announces "clear." No one should be touching the patient or the bed at this time. After successful defibrillation, the patient is assessed for a pulse and adequate tissue perfusion. The patient is treated in the CCU or the critical care unit. Emotional support should be provided to the patient and family as indicated. This image shows the placement of the defibrillator pads on the second intercostal space right of sternum and the anterior axillary line fifth intercostal space. Next, we will learn about synchronized cardioversion. Cardioversion is performed with a defibrillator set in synchronized mode. In the synchronized mode, a mark is highlighted on the patient's R waves. The R waves must be recognized for a shock to be delivered. When the discharge button is pressed, the shock is released when the machine senses that it is safe to deliver the shock. The number of joules delivered with each shock usually ranges from 25 to 50. The procedure is essentially the same as for defibrillation. This procedure can be used for VT with a pulse, arrhythmias such as AFib, atrial flutter, and supraventricular tachycardia. The patient is sedated, monitored by anesthesia team during the procedure. Normal sinus rhythm is the goal for a successful cardioversion. More than one attempt may be necessary to reach the desired goal. Monitor patient for skin burns, rhythm disturbances, and changes in the ST segment. Vital sign changes, hypotension, and respiratory problems should also be monitored. In general, we are all familiar with AEDs. This is an external device that automatically analyzes rhythms. For ventricular fibrillation or ventricular tachycardia, it will automatically deliver or prompt the operator to deliver an electric shock for a shockable rhythm. It is user-friendly with little risk of injury to the patient as it takes away the responsibility of identifying the rhythm. The patient is connected to the AED with adhesive sternal apex pads attached to cables coming from the device. This connection allows hands-free defibrillation. AEDs are widely found in public and domestic places for easy access. Defibrillation attempts must occur within minutes of cardiac arrest to increase chances of survival. An implantable cardioverter defibrillator (ICD) or a combination pacemaker/ICD is placed into the chest of a patient who experiences life-threatening arrhythmia or is at risk for sudden cardiac death. ICDs have decreased the number of deaths from these arrhythmias by analyzing and treating these heart rhythms. More than one shock may be delivered to convert the life-threatening arrhythmia, such as VFib. If VTAC is detected, it cardioverts the rhythm with lower energy. ICDs also have anti-tachycardia pacing ability if a tachycardia is detected. Battery life depends on usage. When battery life is getting low, the entire unit needs to be changed within a few months. These are life-changing events, so we will need to provide emotional support to the patient and family and answer questions as indicated. Here you can see the image for an implanted cardioverter defibrillator. A couple nursing diagnoses for the patient suffering from arrhythmias are decreased cardiac output and anxiety. Please refer to Nursing Care Plan for patients with arrhythmias in your book for details. In the 6th edition, it can be found on pages 454 and 455. This brings us to the conclusion of this chapter. Please do not hesitate to contact if you have any questions. Thank you for listening.